I'm Dr. Rachel Chastanay. Thank you for taking the time to watch this seminar about medical weight loss. This presentation will help you decide if this is the right program for your weight loss needs. Additionally, watching this seminar will help you better understand how our program works and equip you for success. Let me start by telling you a little bit about myself. I'm a retired Navy Reserve doctor, originally trained in internal medicine and family practice, and later board certified in what used to be called bariatric medicine and is now referred to as obesity medicine. In my time as an internist, especially when I focused on hospital medicine, I was frustrated by how limited my abilities were to help my patients achieve really good health. I recognized that obesity was a major contributor toward most of the chronic illnesses I was treating, such as diabetes, hypertension, and sleep apnea. I also had a constant struggle with my own weight and my own genetic risk factors. And I'm married to a weight loss surgeon. So my decision to specialize in obesity medicine, also called medical weight loss, was a good fit. So what exactly is medical weight loss? Well, it's anything that a medical provider can do to help a patient lose weight, except for surgery. It may involve the prescription of appetite suppressants if these are safe, appropriate, and desired by the patient. The best results are achieved by providers who are trained in obesity medicine and practicing in the context of a program that addresses nutrition, movement, and psychological factors, as well as providing practical advice about overcoming barriers. Obesity is a chronic disease, not something you can cure with a week of antibiotics. So a good obesity medicine program needs to be available for as long as you need it. That said, my fondest hope for all of my patients is that someday they get so good at what we teach that they no longer need me. Now, earlier I mentioned that medical weight loss is not the same as surgical weight loss, and that I'm married to a bariatric or a weight loss surgeon. So let's talk just a little bit about surgical weight loss in comparison to medical weight loss. There are some people who are much more likely to get to a really healthy weight by having weight loss surgery than by going through my program. But I like to say that people are not statistics or averages, and I sometimes see people succeed at medical weight loss against all odds, and sometimes people don't do as well as I had anticipated. However, it's worth understanding the average expected outcomes to make better decisions. This graph compares weight loss using 3 different ways to look at outcomes. The teal bars are pounds, and we all know what a pound is, but we also know that a pound loss does not have the same impact on people of different sizes and genders. Another way to look at weight loss is as a percentage of total body weight. These are the blue bars. The percent of total body weight loss is how medical doctors tend to evaluate weight loss medicines. We also look at weight loss medicines and methods in order to properly compare effectiveness using percentage of total body weight lost. The last color is purple, and these bars represent the percentage of excess body weight lost. Each excess body weight is actually the difference between the ideal body weight and the current body weight. Ideal body weight is a number which is determined statistically and is not the same as your goal weight. It's just a tool to help us compare apples to apples when we're starting to try and understand what we've achieved with a weight loss method. Weight loss surgeons tend to use this number when comparing procedures. In this graph, you can see that the average weight loss of my patients is better than published medical weight loss statistics. But you can also see that I cannot compete with the average weight loss achieved by surgery. You can also see that my husband does significantly better than published surgical weight loss data. The Obesity Medical Association and other professional medical organizations have looked at data like what I've just showed you, as well as numerous other studies of risk versus benefit of weight loss options, and they've come up with the following guidance on which patients should be offered surgery and/or weight loss medicines. Insurance companies that cover obesity may also use these guidelines to determine eligibility. But many insurance companies exclude obesity as a covered benefit. This is, sadly, only about money and not about health. Fortunately, insurance does cover the treatment of diseases caused by or worsened by obesity, and this allows me to see most patients. Unfortunately, not being covered means that surgery and medication are generally not covered and would have to be self-pay. Now you can see that the criteria are phrased in terms of BMI. BMI stands for Body Mass Index, and it's another attempt to make it easier to compare different people. This is a calculation that uses height and weight. The easiest way to get your BMI is to search for a BMI calculator on your computer or phone, and then you just plug in your height and weight. Your true BMI will often be a little bit higher because we all get a bit shorter as we age, and most of us don't get recurrent height checks at the doctor once we've reached adulthood. We do an accurate height here. You can see on this slide that very heavy people, or those with diabetes, sleep apnea, or other weight-related diseases can appropriately be considered for surgery if they can't lose enough weight without surgery. A BMI of 30 defines obesity, and this is the point at which it's appropriate to consider the use of weight loss medicines. All drugs have side effects and risks, so they are not appropriate to use for cosmetic level weight loss. Sometimes medications are indicated at lower BMIs due to diabetes, an Asian or Indian ancestry, or prior obesity. So with all this information, what people really want to know is, how much weight will I lose? This slide shows my patient averages, but again, there's a difference between a numerical average and what an individual patient can expect. Additionally, this slide and the next one are in pounds, and we all know that pounds look different on a 6-foot man than on a 5-foot woman. I think the take-home message from these slides is that medical weight loss is slow compared to surgical weight loss, and that younger, healthier people who can take phentermine do tend to lose more. This slide helps us understand that a numerical average is not the same as a typical patient, and that there really is no such thing as a typical patient. That said, my most common patient type is a middle-aged female who takes off about 45 pounds and keeps off about 30-35 long-term. So yes, I have patients who lose very little and may even be higher than they were when they started a year later. That happens. I also have patients who lose over 100 pounds and have a whole new life a year later. So your next question should be, how can I be one of the successful patients? Well, there are some published predictors of weight loss success, and these seem to also hold true in my practice. So let's look at them together. First, how is success defined in order to understand these suggestions? So depending on which study we're looking at, success is variably defined as losing 30 or more or 50 or more pounds, keeping it off 10 years, or it may be defined as reaching and maintaining a body mass index below 30 or losing a certain other criteria. The obesity threshold is 30. Now, some of these suggestions for being one of those who gets to these successful states, some of them may seem pretty obvious, okay? But I think you need to understand that the reason that I have people watch this seminar is that there are people who think there's just a magic pill and are not ready for change. So yes, pills do help, particularly amphetamine pills such as phentermine, but without specific dietary change, they only cause a few pounds of weight loss, and it's not sustained when a person stops the medicine. For this program to really succeed, a person has to be willing to change their diet quite radically in the beginning and less so for maintenance, but nevertheless, a permanent change. Additionally, a person really needs to be committed to seeing the provider and engaging with the curriculum. People who fail to complete the training clearly do less well, especially if they start skipping or delaying appointments very early in the process. People who are older and sicker and less able to perform physical exercise, as well as those who cannot or will not find time to exercise, do less well. That said, weight loss is 85% diet and only about 15% increased activity. So people who try to outrun a bad diet are also not going to do as well. Now, many of you have heard the saying that the definition of insanity is doing the same thing over and over again and expecting different results. Well, weight loss is a classic example of that. If you're not willing or ready to make changes in your life, then please don't come here. It would be a waste of my time and yours. Now, meal replacements. So I know when I first saw that, I found it a little scary. Oh, for the rest of my life to be one of these long-term succeeders, I'm going to have to skip lunch or skip breakfast 1 to 3 times a week. But now I understand better that what it really means is that I need to eat a meal replacement when I'm very busy or traveling or haven't had time to plan a meal properly. It's a tool to keep me from getting too hungry and vulnerable or eating fast food or junk food. Younger people have higher metabolic rates in addition to being better able to exercise and more likely to be able to take phentermine or other weight loss medications. Lastly, people with more weight to lose, it will be harder for them to get all the way down to a body mass index of under 30 and a really, really healthy spot. Now on this next slide, I do not like to use the word failure because not being able to lose weight is most often a genetic thing. And it can be best interpreted as an indication for surgery or in my heavier patients, not a failure. And it doesn't represent failing as a person. But these are some things that predict poor outcomes. As you can see, they're essentially the opposite of the predictors of success. Now let's talk about time and money. Occasionally I have a patient with lots of money, and sometimes I have patients with plenty of time, but very rarely do I find any real people with plenty of both. I think, though, that before a person embarks on a lifestyle change, he or she should take stock and see if, at this time in life, things could be reprioritized to carve out enough resources to enable change. Losing weight doesn't cost a fortune or require hours out of every day, but it does require some money for things like co-pays and healthy food, as well as enough time to attend long and fairly frequent provider visits and to prepare food and to exercise. Sometimes the journey is better put off until a person isn't trying to, say, work 2 jobs and attend school full-time while raising toddlers on food stamps. We need some resources to enable some change. And weight loss shouldn't be an added stress to an already overstressed life. So come see me when you have just a little bit of breathing room to start to make some changes. Now, despite these warnings, I do have patients who lose weight with very few resources, and I have to say the only insurmountable obstacle is attitude. If you're trapped in, "it's not fair" or "I can't," you won't lose weight. So yes, it's true that some people just have really bad genes and that the world is difficult and that life isn't fair, but your only choices are to accept obese and dying younger or to fight back. And if you're ready to fight back and you want someone to help you do that, you are in the right place. If you're looking for a magic fix, this is not the right place for you. The next thing I want people to know after how much weight will I lose is how much does it cost? So please call us and we can take your insurance information, we can contact your insurer, and we can give you an idea on what your cost share, your out-of-pocket expenses will be. There are very few insurances that don't accept us in their network, and we accept almost everything. There are a few instances, such as active duty or uninsured patients, where the patients will need to pay to see us. But we do our best to keep prices very reasonable, and we offer money-saving package deals. Now, keep in mind that self-pay and co-pays can be paid using health savings accounts, and that we do offer financing. And anyone who's previously been involved with any other local programs will be pleasantly surprised by our pricing. Weight loss medications may or may not be covered, and some are more affordable than others. We try to be very cost-effective in our decision making. Now, what does the actual program look like? Ideally, the core curriculum would be completed in 5 weekly sessions, and the remainder of the weight loss curriculum would be completed in 8 more sessions every 2 weeks. Then we would transition to monthly sessions to learn and start practicing maintenance tenets. In real life, my schedule is pretty full, and I recognize that you have busy lives. Some people can get through the whole thing in well under a year. Other people, it might take them 18 or 24 months to get through the curriculum. Some people will be skipped ahead to maintenance training very early, and they may not need all of the weight loss lessons. Some people will continue to see me every 3 months well after completing the curriculum, either because they still need medication or because they still need or benefit from the support here. Each person is different. I prescribe a diet which is very, very low in sugar and in processed carbohydrates. It's high in olive oil and other healthy fats, high in protein, and it uses lots of vegetables. So this is essentially a low-carb diet. Now, I prescribe and I eat a low-carb diet because it works. So I'm a very traditional doctor. I was trained that low-fat is the way to go and that Atkins was a fad diet. Oddly enough, I still tried most of the other fad diets out of just desperation. I used to always be hungry, and I worked very hard at exercise, trying to outrun my bad diet and punish myself for eating too much. And I didn't decide that I needed to try low carb until I'd already decided to be a weight loss doctor, and I'd started studying weight loss information. I felt that the data was just too compelling to ignore it, and I decided that I had to try it before I could offer it to my patients as an option. Now, what I expected to happen would be that I would be telling my patients, yeah, it works, the data's good, but it's just too miserable to sustain in the long term. And instead, I found that I was no longer constantly hungry, and my food tasted better. So I figured, this is too good to be true. I'm going to start gaining weight. My weight wasn't perfect, but it was good enough, and I'd worked really hard for where I was at. And so I figured I would start to gain weight and then I'd have to come off of it. But I continued the diet to see what would happen because I was happier and it tasted better. And oddly enough, the pounds started to slowly come off, and I now maintain it a good 15 pounds lower than when I was starving myself to death and getting up at 4:30 in the morning to exercise. I still exercise though. So the main reason I use a low-carb diet is that it works. It just works better. But being a doctor, I really wanted to understand why. Well, part of the puzzle seems to be the addictiveness of carbohydrates, especially when combined with fat. We've known for some time that rats exhibit clearly addictive behavior toward rat chow containing carbohydrates in contrast to only protein, only fat, or combined protein and fat. We also know that fat combined with carbohydrates is significantly more addictive. Now, I know you're not rats, but there are mammalian studies as well, and recently we have active MRI studies in humans showing activation of the addictiveness area of the brain rather than the hunger area of the brain when human blood sugar is rapidly falling after eating a high simple carbohydrate meal, and then we get this rapid fall. So in addition to breaking this cycle of sugar addiction, the low-carb diet works because your body doesn't read your weight loss as starvation and then lower its metabolic rate protectively like it does in a low-fat diet. In June of 2012, the Journal of the American Medical Association published a groundbreaking study of diets, of a comparison of diets that explained the magic behind the low-carb diet. Patients on a low-carb diet had an average of 326 calories less of a metabolic energy drop on that diet than compared with a low-fat diet. Imagine being one of the low-fat diet subjects. You're eating food that doesn't taste very good and leaves you hungry, and then, oh, by the way, you also need to walk 3 miles a day more than the low-carb people in order just to keep up with them. Now, more recently, a new study showed a similarly higher metabolic rate, about 300 calories, in patients on maintenance or in maintenance with a low-carb diet compared with low-fat lifestyle. Last, but certainly not least, when your body's burning fat as fuel instead of carbohydrates, one of the forms of fat that gets used as energy is ketone bodies. And this is a marker for fat burning, and it tends to curb appetite. Can I just buy a book? Well, yes, you can buy a book, and in fact, I hope you'll buy mine when I finish it. And for some lucky and motivated people, that may be enough. But the data for weight loss clearly supports using a provider and a formal program over just reading a book. And of course, prescription medications to help lose weight or changes to current medicines to help facilitate weight loss require a provider, preferably one well-versed in the use of the available weight loss medicines. Some patients, such as diabetics, may not even be safe to undertake this type of diet without close supervision by an experienced provider. Most people will do better in the long run by completing the full program, but there are some people who need less or more instruction and support than others. I always tell people that reaching their goal weight and then stopping their visits before learning how to do maintenance, before maintenance training, it's like stopping just short of the finish line of a marathon. Most patients should count on working with me for about a year, and we're here for people who need longer care or take longer to get through the program curriculum. So there are some people who will need more and some people who will need less. Now, hopefully you've decided that this is the right place for your weight loss journey and you're eager to get started. Pick up the phone and give us a call, area code 757-312-9444, and we'll check your insurance and we'll make your appointment. If you're planning on seeing your primary care doctor or provider soon, ask the staff there, here for a list of the recommended labs and then request that your doctor do them and ask that they do an EKG already. If you've already had labs in the past year, just help us obtain those from your provider. And we can also order labs here. We do some labs here. And we can also explain how to get labs for the lowest possible cost if you're uninsured. Thank you very much for listening to this seminar. I suspect you'll still have some questions. Please give us a call, 757-312-9444, or contact us by email with any further questions. Thanks a lot.